Ladies and gentlemen, it is such a pleasure to be with you today to be discussing really what hopefully is kind of a dynamic philosophy based on the global vascular guidelines to try to help hopefully keep a few more legs on a few more bodies. Ladies and gentlemen, we give away all of our slides. I just ask you to copy them, make them better, and pay it forward. You could ping me whenever you like for any of these. How does that sound? And we're going to really talk now really about a unified surgical approach based on three rings of kind of intersecting risk, really WIfI made dynamic, because that's what it is. And that's how it works really, especially when you have kind of a toe and flow sort of limb preservation model. And so we're going to really have something of a tripartite, because things come in threes, as it were. 5 or 10 minutes together today. We're going to talk about three rings of risk. And in that area, we're going to broadcast our WIfI settings. We're going to talk about a surgical philosophy focused on these three rings, both for wound or tissue loss, for ischemia, and for foot infection. We're going to look at a case or two for each of those. And then finally, we're going to talk about the diabetic foot in remission. We don't have time to talk about cases associated with that to extend ulcer-free days, but more just the philosophy, as it were. But the big idea here is when we're evaluating a patient, we really have to ask what is dominant. Is this a tissue loss dominant condition? If that's the case, well, close the wound. If it is an infection dominant condition, well, that often takes precedence. Get rid of the infection or address that. Is it an ischemia dominant condition? Well, address that. And these are all sort of intersecting rings of risk. And that's really what brings us to WIfI. And what are we talking about? Many of you have seen this already, but let's just review our WIfI settings, looking at tissue loss on the left, ischemia in the middle, and foot infection. So wound, ischemia, foot infection, making WIfI. And just like with tumor node metastasis in cancer, we really have none, mild, moderate, and severe here for each one of these things, both for the wound, for tissue loss, none, mild, moderate, severe, as you see here. For ischemia, none, mild, moderate, severe, depending on if you're looking at hemodynamic or tissue perfusion related issues, and for foot infection, none, mild, moderate, severe, based on the Infectious Disease Society of America's guidelines. So that is the big picture here. The thing about this, though, is that these are always changing and they're always intersecting, and this is dynamic. And that's why the team has to be dynamic in an interdisciplinary sense in addressing these. But now let's talk about together as a family, if you will, maybe surgery, addressing wounds, infection, addressing ischemia, and addressing foot infection in that order. So if we're looking at addressing tissue loss, the big idea here is what causes diabetic foot ulcers or purely neuropathic ulcers in the face of neuropathy is pressure times activity. And that's what leads to this sort of imbalance that essentially allows a patient to wear a hole in his or her foot. And you have to bring that imbalance back into balance. That's the big idea behind any kind of surgery that you might be doing, trying to close up a wound, or at least in the reconstructive type, because there are really two flavors to non-vascular diabetic foot surgery, and those are reconstructive foot surgery and then just getting the wound closed. Let's just briefly look at an idea of a reconstructive type of foot surgery. This is a patient after a proximal transmetatarsal amputation, and you see his foot is in a varus position. And so you see here Tanzim Khan, one of my partners at this time, he was my fellow, doing a tendon transfer, just bringing that anterior tibial tendon over just to give it some good balance. And in doing that, you can bring something that is out of balance and probably not very functional into balance and be very, very functional, so that he can have more activity as this patient, moves through his world. But another type of surgery that one can do in terms of tissue losses, wound closure surgery. And here we really have a couple of varieties. You have split thickness skin grafting. You see this done for a fasciotomy, but theoretically it shouldn't be much different than this done for a guillotine TMA, as you see here, or for a plantar diabetic foot wound, assuming that you can spread the force over the entire unit area, as you see here for this plantar foot wound that had a simultaneous tendon balancing and panmetatarsal head resection. And what you see here from data from almost a decade ago now is that indeed that is the case. For just about 100 patients, we saw almost 7 in 10 patients have complete incorporation of a skin graft, a 20% required revision, but that was usually pretty minor. And almost all of those patients that required revision were the sickest patients. They were those patients that had CKD stage 5 most commonly in this patient population. So you shouldn't feel like skin grafting is verboten to close a diabetic foot wound, especially after you've optimized the patient for ischemia and foot infection. And here you have a patient who has a wound on his posterior heel. He was scheduled for a high-level amputation, but instead of doing a skin graft, and you see me doing a partial calcanectomy here, my partner Keaton Patel at the time did a superficial circumflex iliac pedicle or skip flap. And this kind of free tissue transfer that is not very metabolically demanding can be really attractive in this patient population. And so that is yet another way to close these wounds. Now let's move on from infection, or I should say for wound closure surgery, to ischemia surgery. You don't need me to show this, but this is a patient of Joe Mills and me. And this is the angiogram beforehand. This is the result after Dr. Mills did an angioplasty, as you see here, beautiful, almost 70 millimeters of mercury of flow there. And now, after that, all we can do is just close that wound. And you see the skin graft here on this patient, which had a previously cadaveric leg and a BKA on the other side. And all she wanted to do was dance at her mother's, I should say, at her granddaughter's quinceañera. And you see that happening right here. And there she goes. She's doing the salsa in the hallway. Almost fell, freaking out the nurse, but all is well. If these patients are going to get in trouble, we want them to get in trouble doing something, not doing nothing, right? So finally, just very briefly, let's talk about foot infection. This usually takes precedence over both ischemia surgery in terms of timing and wound closure surgery. But you see here, this is a patient that has that was referred to my partner, Greg McGee, who's on Vascular. He identified maybe a little bit of pus there dorsally. This tracked all the way up the leg. So you see here, this is a simultaneous procedure being done with my Flomigo, Greg McGee, who also did an angioplasty under the same anesthesia. That then was VAC'd and later converted 4 weeks later to a skin graft, which you can see here, step by step by step, wound infection, wound ischemia, and wound closure surgery in that order. We don't have time to talk about this, but I'll just briefly say that, looking at not just at foot ulcers, but their recurrence, or ischemia and its recurrence, is the flavor of the day. Nothing ruins a good surgery like follow-up. And let me just show you this. After 1 year, about maybe 4 in 10 of these patients are going to get another wound. It's about 2/3 at 3 and maybe 3/4 at 5. So recurrence, ladies and gentlemen, is not only common, it's darn near likely in this population. So if the foot in diabetes is a little bit like a cancer, and we haven't talked about that in this lecture, but if we look at cost and complications, one could make that argument that maybe when people are healed, maybe they're not healed, maybe they're in remission. And this is it sounds like a coin of phrase, but it's really, really important, because if you think about it this way, if we assume that this patient is going to get a recurrence of their wound in their long life, or a recurrence of their ischemia in their long life, then the goal here is to maximize those ischemia-free days and those ulcer-free days and activity-rich days for that patient population. So, ladies and gentlemen, in conclusion, we end where we started, with these 3 intersecting rings of risk, this sort of unholy trinity of tissue loss, ischemia, and foot infection. And our goal is to bring this imbalance really into balance, in order. And it doesn't stop when the patient leaves the operating room. It doesn't stop when the patient leaves the clinic. This is over his or her entire life, from the alpha to the omega. And here's to making a difference for our patients and helping them move through the world a little better each and every day. Ladies and gentlemen, thank you so very, very much.